uniquely challenging and unique case that we were able to do successfully, not in small part because of a collaborative effort. I was not the only interventionist involved in the case. My colleague, Dr. Lopez Sanabria, scrubbed in with me.
Okay.
Elliot Elias was the echocardiographer, so even though he never touched the patient, he was critical to guidance in the case. And together we were able to accomplish something that is quite rare indeed. As I said, there's been fewer than a dozen cases done in South Florida. This is the first one of that.
Do you know other healthcare institutions in South Florida that perform this specific procedure?
Sure. So the highest volume has been performed at Cleveland Clinic in Weston.
Okay.
Cleveland Clinic here? Or, yeah.
In Weston.
In Weston.
Yeah. Does Mount Sinai or JMH perform these?
So neither one has done one. In fact, actually, the patient went to Mount Sinai to get an opinion and was turned away.
Really?
Oh, okay. And UHealth? Same, right? No, they don't perform that?
He saw a surgeon there, but to my knowledge, there has not been a basilica done at UN.
Okay.
The only basilica done in Miami was actually at Palmetto General. Believe it or not.
Okay.
Yeah. Okay.
Palmetto. Okay.
So,
And how many do we know nationwide how common it is, or how many have been
so
done?
it is something that's typically done at quaternary centers. The Cleveland Clinic, Mayo Clinic type thing.
Okay.
According to the proctor, he mentioned on the order of 200 cases of this total.
Okay. And do you know what time span we're talking about? Since when? Or
the procedure was really first. Hold on, I can actually pull up the paper for you. So it was a clinical trial, and the results of that trial were published in. One moment.
Mm-hmm.
2000. It was just published in 2019.
Oh,
the
really?
results of the clinical trial.
Oh, okay.
So it only became sort of commercially available,
Oh, fantastic.
trickled down to non-experimental operators really this year.
Fantastic. Okay. Fantastic.
And then it's something that is so new that there's no billing code for it. So you don't actually get paid any extra for it because CMS doesn't realize that it exists.
That is new. Okay, definitely. And if you have is there a published results findings? If you can, I don't know if you have access to it. If you can email it later, that would be fantastic, or just the link.
Yeah, I'll send you the paper.
Oh, yeah, fantastic.
Yeah, the Basilica trial, absolutely.
Can you?
And so this is a procedure that is, as I described in my email, used for the treatment of mostly surgical aortic valve stenosis.
Right.
So is this similar to TAVR, doctor?
So it is TAVR, except there's a step before the TAVR.
Okay.
All right.
The idea being that patients who have had surgical aortic valve replacement have a high risk of mortality for the repeat operation. Okay.
Okay.
So TAVR in surgical AVR has been approved for at least the last 3 years or so.
Mm-hmm.
And everybody's been very excited about that because you spare the patient the operation. The problem is that not all surgical valves are the same, and that the height, the distance between the mouth of the coronary arteries or the opening of the coronary arteries and the valve is variable. So in some patients, the opening is low. And so what happens when you put a valve inside, and if you look at that link that I sent you, that's a very nice picture, actually.
Right.
When you put a valve inside of the surgical valve, the leaflets come up, right, and then can obstruct the coronary artery, which is a fatal complication.
Right. And
so you're able to predict that. I'm sorry, based on the CAT scan that you do before the procedure, you can predict that will happen.
And this is a subset, obviously, of patients that are qualified for TAVR.
Yes.
How big? I mean, I'm sorry. Well, what do we know? What percentage maybe of the subset represents in terms of TAVR patients that would need or may benefit from?
I can't give you a number to be honest.
Okay. All
I
right.
don't know. However, the incidence will certainly be going up because the lifespan of a surgical prosthesis, of a bioprosthesis, is about 10 years. So if a patient has surgical AVR at age 70, he'll need my services at age 80.
And as a lifespan, or as people live longer, this will be more common, of course. Can you walk us through this patient And, I know we're not gonna name, is it her? It's a she, I'm sorry.
Yes.
It's a lady. I'm sure she'd be happy to talk to you, actually. So she is 65. She is a Jehovah's Witness.
Okay,
Who had surgical AVR and bypass surgery about 10 years ago. And she has two problems. She has severe symptomatic valvular aortic stenosis. That is, the lifespan of her valve is ended, and now it's calcified and stiff.
wow,
The other problem is that the valve that they put in for her at that time was actually too small for her. Okay? Such that even when the valve was working,
There was still obstruction?
enough blood really,
the blood flows.
enough blood couldn't come out
Right.
that she was still short of breath.
And this was this was done somewhere else, I assume, or we don't
This
know?
was done in another institution.
Okay, yeah.
That you went to. And so she was referred to me, and her heart's pumping function was severely diminished as a consequence of the stiff valve because the heart was super stressed.
Okay,
Okay? And she had symptoms at rest. We know that the mortality for those people approaches 50% at 1 year.
right,
Yeah, it's actually, the real statistic is 50% at 2 years, but given how sick she was. So we initially investigated. We thought she'd be a great TAVR candidate, but the problem was this valve to coronary height issue.
mm-hmm.
The patient sought several opinions. She was seen at every major institution in this city, and even sought guidance elsewhere. She was turned down for repeat operation because she is a Jehovah's Witness who refuses blood products. And there was no interventionist who was interested in pursuing the case for her. And so after some deliberation and some research, I let take it on. I spoke with my colleague, Dr. Elliot Elias, who's an expert cardiac imager.
Mm-hmm.
We looked at the heights and so on and so forth. I discussed the options with my colleague Lopez Sanabria, who's also an interventional cardiologist.
Okay.
And in collaboration with Medtronic, we had a proctor who actually developed the procedure come from National Institutes of Health in Washington, D.C.,
Wow.
to come and walk us through it as we did the case. I met with the patient. I gave all the patients my cell phone number. Her family called me to sort of figure out what the story was. It's a little bit challenging for me because they're all Spanish speakers. I speak Spanish, but it's hard to explain in English. And after a careful decision, we decided that she couldn't live like this anymore,
Right.
and so she was willing to take the risk. So we did the procedure, and that was successful. And then what we did at the end of the procedure is that the valve that we put in, the catheter valve,
Mm-hmm.
is actually bigger than the surgical valve that she had.
Right.
Okay. How do you do that? So, and the surgical valve has a metal and plastic ring around it, okay, that constrains the transcatheter valve. So what we did at the end of the procedure then was that we took a Kevlar balloon and deployed it at high pressure. So when we say balloon, it's not a party balloon. The pressure in the balloon are actually greater than the pressure in your car tire. Okay?
Wow.
So the valve is 19 millimeters. We put a 20 millimeter balloon in, deployed it at high pressure for almost a minute, and we fractured or cracked the surgical valve ring in order to allow the transcatheter valve to expand. And now she has a valve that is actually bigger than the valve she had when she had her operation.
Was that procedure you just mentioned, that portion of it, is that part of Basilica, or is it
No,
is it additional?
That's a separate exercise. So what I did was Basilica, followed by TAVR, followed by valve fracturing, balloon valve fracturing.
Balloon valve fracturing, is that sort of standard for this type of situation?
So it is.
It's nothing standard in medicine, I guess.
Right. So it is a relatively recent innovation
Okay.
in transcatheter valvular therapy,
Right.
which is not widely practiced, but should be.
Okay.
So that's another unique thing that it can offer.
But it's basically fixing the issue that was was there from the
So
surgery.
we fixed two issues, right? We fixed the fact that her valve had run out of its warranty,
Right.
and then we also fixed the issue that her valve was already too small to begin with.
Right. Right. And she was she's young, 65. So I mean, this gives her
5,
yeah.
vibrant
Yeah.
woman, who, grandchildren, wanted to live her life.
Right. Right.
And we were able to do it with minimal blood loss. We were actually very conservative in our blood usage, and the patient went home the next day.
The issue of the religious and I don't know how we're going to mention this,
Yeah.
probably just not even mention her religion, but say for religious beliefs. But what
She just refused a blood product.
but
Patient refuses blood products, which is makes repeat surgery impossible.
well, that's my what begs the question is, was there any issue in the initial surgery with that in her 10 years?
Right. So apparently not. I mean,
Okay.
so she lost blood, but the surgeon was able to do everything quickly. So
Okay.
first-time cardiac surgery is very different from repeat cardiac
Gotcha.
surgery.
Okay, understood. Got it.
Because there's a lot of scar tissue. You have to deal with the bypass grafts. It takes a lot longer to get into the chest. So the mortality for second chest opening for repeat bypass or repeat cardiac surgery is somewhere between 4 and 10%, versus less than 1% for the first operation.
So we can say in a second follow-up surgical open heart, there's more likely to be a blood product, a complication that would require blood products, right? Okay.
Yes, it's almost guaranteed.
Okay, that clears it up for me there. And then she's okay. Everything's what's her status now?
She's home right now.
Oh wow. Okay.
I thought she called me last night to let me know she got home. Feeling great, walking around.
And the procedure.
She got out of bed the same day.
When was it done? What day?
Wednesday. It was on Wednesday.
Wednesday. And she left yesterday?
She left yesterday.
Oh,
she was out of bed on the first day. We finished the case around 12:30. I came back and saw her. I got her out of bed around 8 p.m. And then she went home the next day.
So she was walking the next day and left.
She was working the same day.
The same day.
Working the same day. Working the same day. And her heart's pumping function actually improved. So her heart's pumping function was severely reduced, and her heart's pumping function was almost normal the next day, because basically we took the parking brake off by replacing the valve.
Got it.
I like that. Parking brake. People can relate to that, see?
Yeah.
And fantastic. And this was I'm sorry, it was at SMH?
Yeah.
Okay.
No, this was done at Baptist.
Oh,
okay.
Baptist.
Yes, it was done at Baptist Hospital. So I'm a private practice cardiologist. I'm part of the South Miami heart specialist, now known as my cardiologist.
Okay.
24 cardiologists. We see patients both at Baptist and at South Miami. We're very much aligned with the institution,
Okay.
and so on and so forth. I have my other job. I have started the TAVR program at South Miami.
Great, yeah. And we talked about that earlier.
But I also do cases at Baptist that require collaboration with my other colleagues, because for a variety of reasons.
So I guess the big takeaway from this is that this is yet another option for folks, and then there's folks out there who've had this surgery years ago. I think even Arnold Schwarzenegger had it. I think he had to go back in. This was in the news a few months ago, and this is one more aspect of TAVR.
Right.
And that's go ahead.
So this is an aspect of TAVR that allows patients who have no other options to have a transcatheter therapy and they'll be discharged the next day. It also gives patients the option to have transcatheter therapy instead of surgery, and the result is actually probably better. The valve that she got is bigger than the valve she would have gotten from an operation, with certainly less recuperation time and so forth. It is a unique procedure that we were able to do because I took a very collaborative approach, right? Because Dr. Lopez Sanabria is not in my practice, but we work together. Right? We're not in the same group. We wear different coats, and so on and so forth. But he's a great guy, and we like to work together. Dr. Elias is also not in my group, but we work together. We're the young guys here who take a collaborative approach to patient care, true heart team stuff, similar to what I used to do when I was at Cleveland Clinic in Ohio. I think that the takeaway is that we are a collaborative organization that is able to do innovative procedures for our patients and get them out of the hospital quickly so they can go back to their lives when they have no other options and have been turned down everywhere else in South Florida.
Fantastic. Couple quick minor. The patient, do you know what she retired, or do you know what her profession was?
Yeah, she's retired.
She's retired. Do you know what she did? Or?
I don't know what she did for a living,
okay.
to be honest with you.
And she has, you said she has kids and grandkids?
She has children and grandchildren.
Okay.
All of whom I've spoken with on the telephone. It's quite a large family, actually. Who all came with her, and she takes care of her grandchildren. And she was short of breath walking from the living room to the kitchen.
Wow. That's
And she was taking naps, 2 and 3 naps during the daytime, and had swelling in her legs and her feet. She would wake up in the night short of breath because fluid was backing up in her lungs. She was quite sick.
wow. That's good.
And she never quite felt well even after her first operation because the valve was too small for her. Now she tells me she feels like she did it before she had the problem, 15 years ago.
Wow, fantastic. Yeah, I don't know if you think she would be. Is her English? How's her English?
So she does not speak English, so that's the
Okay.
challenge.
That sort of puts a little. I mean, I guess we could try and do
Just translate her.
Yeah.
But what I can do, I can call her and I can ask her whether she'd be willing to talk to you.
That would be
great.
That would be great, and we can.
Take it from
muddle through in Spanish, and then I can, for the article, I can easily, for a video, it'd be a whole different story, but for an article, it shouldn't be a
Yeah.
problem for us. But yeah, let's say if we would need to, the waiver, I guess, right?
Yeah,
For her to
a
give her
release.
name and all that.
Yes, but doctor, if you could, if you could make that connection and just let her know that we are interested in speaking to her to develop a blog. We're gonna develop it anyways with your information, but it would be great to have her perspective about her experience and how she's feeling now.
Yeah, no, that would be fantastic.
And then I'd like to have my picture because you guys did a nice piece for the South Miami TAVR program. There's no
Yes.
photograph of us. We took a nice picture of us, of Dr. Garcia and myself, and doing the case at South Miami. I could send you a headshot, or you can take my picture from the Baptist computer. But I think adding a photograph would be nice, at least for me.
Is it a photograph of the team, or did you say?
Well, I don't have a photo of the team.
Okay.
But I think,
All right.
because, who am I? I don't know.
Is there
And I'm going to see the patient. I can also send you a picture of the patient and I together if she's amenable to that.
That would be that would be great. A picture. We like patients of doctors and the doctor and the patient. That would be fantastic.
Yeah, I'm sure you do. And then I think, the pictures of Lopez Sanabria, of myself, and I can take that picture on Tuesday, to show, look, we are young guys. We're guys in our 40s, okay? Who have cutting edge training, right? And we are ready to do this for you. And we can do it, and we have great outcomes.
Oh, no, I understand completely. We generally don't post just the headshots of doctors, to be fair to everybody.
Okay.
We do it when it's with a patient or it's nothing like at the hospital so the best situation, the best shot would be of you and the patient. Generally, we just don't post pictures of doctors. That's pretty much across board the whole system. We got to be fair.
That's part of our branding guidelines.
Yeah.
But we will try our best. If you have a picture of you and the patient, that would be fantastic.
Yeah, I'll do that.
That would be a way of getting around this thing.
Yeah.
Because we all.
Right, yeah, because I see in the magazine they have lots of pictures of the doctors just by themselves. So I guess it's different on the blog.
On the blog it's different,
on the blog it's different.
Yeah, so since unless there's a submitted op-ed by the doctor writes an article for us, then maybe we'll put it at the bottom. We'll say this is the author is the so and so, But otherwise, But the way to get around that is we do it with if there's a shot with the patient, that's perfect. Then you have both.
I'll do that.
Yeah, that'd be fantastic.
Wonderful. Well, thank you, friend.
No, thank you. And go ahead and send me that study results of the Basilica.
Yes,
that would be
the trial.
That would be fantastic. And then get back to us on the patient, and then we'll take it from there. I mean, we'll hopefully put this together next week. Or something.
Super. All right. Well, thank you very much.
Thank you, doctor.
Thank you, doctor. Great job. I appreciate it.
We'll expect, I guess, your call
Or
So you'll get an
regarding
email
the
from me later
patient.
today,
Yeah, get an email from me. Yeah.
and then I'll
Fantastic.
send you an email about the patient also.
Okay, we'll
Thank you, doctor.
Thank you very much.
Cheers. Bye-bye.
Take care.
Bye-bye.
Bye-bye.